how a lung feels when you ventilate. So I request all of you, whether you are anesthetist or non-anesthetist, after going through this workshop, please try to go to your anesthetist friends, especially for the non-anesthetist delegates here. At least ventilate 5 patients with an anesthetist bag. Try to feel what is the feeling of lung in your pump. Then only you will be a very good intensivist, because this knowledge will be during the control of the ventilation. These are the few basic things before I start the whole thing. And as it is a mixed gathering, I have to modify my total deliberation. Today's workshop is based in 2 segments. Pre-lunch segment is absolutely theoretical dedication. Maybe if I get some time to maybe on some simulations, and post-lunch will be on hands-on in groups. In 3 you have to divide into 3 groups in 3 different machines. We'll show you, and you have to control the machine. You have to learn from the machine how you have to operate the machine, what are the advantage, disadvantage, what are the controls, all these things. Without wasting many more time, huh? No, I think I am audible to everybody.
Yes, sir.
This is a scenario of an ICU. See, lot of machines, lot of wires, lot of gadgets, lot of preventive mechanisms are there. But ultimately what happens? The patient is entangled with only lot of words like our chow mein and all these things. And a nomenclature has come into the dictionary that is known as spaghetti syndrome of the patient. What is spaghetti syndrome? Spaghetti means the noodles. The patient feels like he is in a platter with spaghetti. Because most of our intensive care patients mind that they are awake. In theatre, operation theatre, patients are unconscious. But what is the difference between an operative patient and non-operative patient? That most of the ICU patients are awake. They are looking at you, they are looking at the different atmosphere, and they are looking at the gadgets. And some may be educated, some may not be educated. Lot of psychological outbursts are going on because of this spaghetti syndrome. So you have to take care of this thing. Now coming to the ventilator itself. This is the master diagram of ventilator. Any ventilator, please, before going to the details of the ventilator, I am directing you to look at this picture, because this is a master picture. Why I am telling this is a master picture? Because any ventilator in the world, they have to have these components. Whether it is a low end, maybe 50,000 rupees ventilator, maybe 50 lakh rupees ventilator. All the ventilators have to go through this master diagram. So it is common to all. So please very carefully note this picture. First, what is that? This is an arbitrary diagram. All the machines, what they do, they give delivery of breathable air to the patient. What is breathable air? It may be atmospheric air, it may be enriched air. So you have to have an arrangement for enriched air or natural room air. For any long-term ventilation, the natural room air is the best carrier gas. With FiO2 0.21, that's the normal room air FiO2. So the machine should have a mixing arrangement. The mixing arrangement may be mechanical, electronic, any modality. But basically the mixer has a role. It has got 2 inputs. One is the oxygen and other is the air. Then the 2 gases mix as you desire. If you desire the 100% oxygen, this should be able to deliver 100% oxygen. If you desire no oxygen at all, then only it will deliver 0.21 air. Then it goes through some pipes to a valve which is known as flow control valve. It is just like mimic a tap of our bathroom. You open a tap, water will come out. Like that, if you open this control valve, air will come down from the machine. Air will come down from the machine. But problem is that the whole setup of this, up to this, beyond this white picture, all are covered under bonnet. If you don't open a bonnet, you can't see an engine of the car. So as in the ventilator also, you don't have all this, what is inside. Only you can have control outside, just like an self-starter in the car and other switches like that. So from this flow control valve, which is not visible to you, only you have an access to the tap. You can increase or decrease the flow of the water, like that you can increase the flow of the water. So from the outside of the bonnet, you have to attach the patient circuits. This is really the patient circuits. The pipes which sits in the ventilator. It may be silicone, it may be PVC, it may be latex, anything, whatever material you use according to the price or variability, you can use any type of pipe. These are basically non-pinkable patient breathing circuits. Once you open this control valve, the air will start passing out through this pipe like with a hissing noise. That means beginning of the inspiration. From air goes to this pipe. Then there is a connection, the Y connection, where you can put your endotracheal tube. This is an endotracheal tube. And again from this another end from the limb of the Y, the exhalation port, the exhaled air from the initial air goes into the lung of the patient, then exhaled air come out from the lung during the natural relaxation of the thoracic capacity. I am reminding you, this total ventilatory technology only for inspiratory maneuvering, nothing else. The exhalation, we don't have to do anything. We depends on the patient own elastic recall of the lung. So when air starts come out, means you have to stop somewhere this inspiration. If you continue to flow this from this valve, continuous air, then what will happen? The patient will burst. So you have to stop at some point of time this valve. That will be taken over by the inside machines. Then the exhaled air will come out, swiftly. Now question comes, if you look at a ventilator in your institution, you will find there are two types of ventilators available in the market. One has got the double lumen circuits, means two pipes going to the patient. Two 220mm corrugated pipe going to the patient. In some ventilator you will find only one pipe going to the patient. And now you can ask me, I am telling this is a master picture for all the ventilators. But classically, all are same. Whether it is a one limb circuit or two limb circuit, basically all are same. They will corroborate with this diagram. Now coming to the why it is same. See, at the end of the expiratory limb, there is an exhalatory valve. Unless you close this valve, what will happen? This is a preferential least resistive pathway. The entire air coming out from the patient will come out through this pipe and go out. It will never go to your patient lung unless you block this outlet. Then only lung will inflate. Because these are the preferential least resistive pathway and this is the resistive pathway. The lung has got its own resistance and compliance. So air will never go into the lung unless you close it. So you have to have a thumb on this outlet. If you close this outlet, then only lung will open. If you remove your thumb, again lung will deflate. So in tandem, once it is open, and in next phase, the closing of this, simultaneous closing of this, and opening of this valve and closing of this valve. These two things operate any ventilator in the world. If you look at any ventilator, these two are the basic valves which controls the machine, entire mechanism. So this is very easy to you now. Now comes sophistication. Before going to the sophistication, I'll tell about what are the essential components of a ventilator. What are the essential components of the ventilator? This is an air mixer I have done through this mixing device. Just like our anesthesia, those who are anesthetists, they may know the nitrous oxide oxygen we give 4 liter, 2 liter like that. So we mix up the gases according to our wishes. Here also the same thing. It may be flow meter, it may be preferential controller, valve, anything. Whatever the technology, ultimately is basically a mix of gas, and it is going out from this bonnet to the outside patient circuit. Now what you have to assure? You have to assure that patient is getting the desired FiO2 what I have decided. Normally, all machine have the master control that it can never deliver an air below 0.21 FiO2. Why 0.21? Because 0.21 the basic necessity for human being. Without the basic 0.21 delivery, human life is non-sustainable. So you have to monitor what are the percentage of air or oxygen I am giving to the patient. Whether it is a desired, I have said here say 50% oxygen. 50% oxygen, 50% nitrogen. Nitrogen is the other carrier gas in the air. So you have to check whether this component of a machine has worked properly or not. Because this, after all, is a machine. It is an idiot. Idiot can fail any time. I have set in dial 50% oxygen. But I have to check whether the machine is able to deliver 50% or not. To check that, you have to have an oxygen monitor here. It is customary as per ISO standard specification in the International Standard Organization. All the anesthesia machine and all the ventilators should have an FiO2 monitor at the outlet. Means the first point, because you cannot see this part, it is inside the machine. And the first outlet is the where you are attaching your ventilator circuit. At this first point you have to check that air is having 50% oxygen. How you will measure? With an oxygen analyzer. There are plenty of variety of technology in oxygen analyzer. I am not going into the details of the oxygen analyzer because I don't have a time. Then I have to have a 3 days workshop on ventilator. Then I can go into the details of the other technologies also. So basically you are, remember only, you have to have an oxygen analyzer at the outlet to ensure that this 50% is displaying here as 50%, FiO 2.5. Now you are sure that the machine is working properly. I have set 50%, the air coming out from the patient is 50%. Now you allow this air to go into the patient lung by closing this valve. Now this is going where? Into the patient lung. Look at this diagram again. This is the endotracheal tube. I am not going into the mask because more or less both are the same. Think about this. This is the endotracheal tube cuff. And where it goes? Into the trachea. Suppose the tracheal diameter is 12 millimeter and you have put an endotracheal tube of 7.5 size. So there is 50% leakage around the endotracheal tube. So you have to block this so that air doesn't come out around the tube. So you have to inflate the pilot valve. How and how? I am not going into this. But if you do not inflate this cuff, what will happen? Again remember, the lung pathway is a high resistive pathway than this circuit. So once machine starts delivering air to the patient lung, the next phase, at the acceleration phase, when this valve is open or inflated or closed in any position, whether in the inspiratory phase or expiratory phase, what will happen? There will be a tendency of leaking gas around the endotracheal tube into the mouth cavity. If the mouth has a saliva, you can notice some froth and all these things around the tube. But this is if you are vigilant enough. Or you can check with the stethoscope whether lung is getting empty. But how do you assure that patient is getting a proper tidal or not? Ultimately, in ventilator technology or in a manual ventilation, ultimate determination is the minute ventilation. Means how much air you are allowing a patient to breathe per minute. That will be the ultimate target of any ventilator therapy. So by clinics, it is impossible to assess how much air is going to the patient per minute unless you have a monitor. You have, this is just like a tap as I told you earlier, just you are opening and hissing noise may increase or decrease according to the opening of the valve. Initially if you open slightly, it will noise like, if you open widely, it will like that. But ultimately, you are not sure about how much air is going to the patient lung. The determinant is the main problem. So you have to have a monitor here. What is that? You should have a flow sensor. What this sensor will do? This is a flow sensor. Flow sensor may be here, flow sensor may be here. If it is a single limb circuit, flow sensor will be at this position. If it is a twin limb circuit, the flow sensor will be at the outlet. Why the international dictum, like ISO organization has said, oxygen analyzer in this position and flow sensor at this position. What is the analogy behind? I have explained the analogy of oxygen sensor here. Now I am going to the flow sensor analogy. Why ISO has given a directive to attach flow sensor at the exhalation port. Now flow sensor is here. What is the work of flow sensor? The flow sensor will pick up the velocity of the gas. And in this pickup will be converted to a numerical figure as a quantum of air. The maybe cc per minute or liters per minute, like that, they will display in your thing. But basically it picks up the velocity of the gas and quantification of the gas. So that is to be displayed anywhere in the machine or in the external juggler. But as it is there, if you don't have a leak-proof arrangement here, then what will happen? Say I have delivered 500 ml gas in one inspiration. It is going to the patient lung is inflated, now no gas supply, this is open. What is the rationale say? The 500 ml as it goes to the patient lung, it has to come out during exhalation through this tube. I have given 500, 500 should come out. That is the ideal situation. Understand? Now suppose there is a leak here. What will happen? Maybe 200 ml has gone to the patient lung and 300 ml has come out by the leak. So you have not achieved the target of delivering 500 ml. So to ensure that the 500 ml flow sensor, if you attach here flow sensor, what will happen? That will display 500 ml. But you are not sure about whether this 500 ml has gone to the patient lung or not. So in the return pathway, if you measure, then only you can understand that suppose in Mandir, there is a queue. a lot of people are queuing, and there are a lot of bypass and barricades. They can go to down the lane on this thing and somewhere. But if you count people at the exit on the temple or any mela or anywhere, then only you can say that these people has visited that place. Like that, if you have an exhalation counter here, then only it is actual. And another important thing is that, look at this. This is the anesthetical tube and these are the patient breathing circuit. There is a snap feed connector. All are push feed connector. No latch, nothing else. You are all aware about this. These are all push feed connectors. Suppose most of the patients are conscious or maybe violent or anything, or even during nursing, say the patient has turned their head and it gets disconnected. Then what will happen? Immediately, if the sensor is here, immediately it will say there is a disconnection because there is no airflow. After a lag period, maybe 5 seconds or 6 seconds, immediately it will display there is no airflow. Means it is leaking somewhere or disconnected. So the exhalation has to be measured here. So now you have understood the basics of delivering air to the patient lung. Now comes to the inside of the machinery. Nowadays, most of the machines are electronically controlled machines. There is a microprocessor inside. There are a lot of inside. Now you have the controls. You can have control on the machine. You can put your desired values. Say I want 500 ml tidal, 12 respiratory rest, and some flow pattern and all these things. From very basic, the two things, and the pressure. Target is the pressure. How much inflation pressure? All you can put to this microprocessor, and microprocessor has got a book inside in his memory, that is random access memory is put here. Random access memory picks up the signals from this two oxygen analyzer and flow sensor and interact with the ROM, which is already inside the brain of the computer. They interact and finally they dictate the term to this mixer, flow control valves and exhalation valve. There are other lot of things, but I don't want to confuse because this is the first class for you. So I don't want to confuse all these things. How a machine works, basically you can learn. Now if it is a non-electrical machine, then all this work can be mimicked by pneumatic logic circuits. That also can work. The basic example of a pneumatic logic circuit is, can you say, especially I am asking railway people, any idea of the pneumatic logic example? Of course, nowadays nobody has, Indian Railway has taken out all these things. Steam loco is the best example of pneumatic logic circuit. Because in that loco, it doesn't have any electronics, doesn't have any electrical system. It has a pressure source, that the water is boiled to a certain pressure and that feeds them to two systems. One is the master piston, from where it goes to the patient or the operator. Then what happens? There is a sliding valve. Like this inspiratory and expiratory valve, that small piston both works together and a flywheel moves. That was the basic principle of a steam engine. So if you mimic the steam engine to this ventilator technology, that is also same thing. If you have a compressed air set from the cylinder, if you fit this compressed air and make an engine like steam engine, that also will work. Without any electricity, without anything, only with the air pressure, the machine works. And you have a moving object, a flywheel. So you have your own ventilator. But basically all these are of same technology. Whether it is electronic or pneumatic, basic idea is flip-flopping. Forget about the technology. You remember only flip-flopping. Opening of this valve and closing of this valve. this flip-flop will operate your ventilator. This is another way of displaying one thing for the anesthetist colleague, because all the machine nowadays, the anesthesia workstation, they are incorporated the ventilator. Only in that, what is the difference? They have the flow meters for nitrous oxide and oxygen. Other things are more or less same. Now comes to the introduction. I think any question? If you don't ask me anything, I can't explain you properly. For most of the after 3-4 slides, I will ask you to give me feedback. Up to this, is it okay to you? Clear? Now comes to the clinics. Any question? Mechanical ventilation. When? Just read at this. Routine anesthesia and post-operative management of major surgery. Everybody knows. That respiratory impairment, parenchymal maybe, airway or chestal problems. Then central nervous system or neuromuscular impairment. And fourth one is the most important in ICU technology. Directly not related to the lung itself, but when there is a circulatory failure, because after all, the CVS and respiratory system works in a tandem to survive a patient. So when there is a chance of circulatory collapse or patient is on circulatory collapse, in that point of time also you can apply this ventilator technology. So these are the basic technology. The basic and important is the respiratory impairment, the basic idea. Along with that, you have only advantage of these two patients, the central nervous system and circulatory failure patients. Their lungs are mostly a healthy lung. So to ventilate it, break the loop. So for last two varieties of patient, the application is more or less easy because their lung is not damaged. But the second variety of the patient, respiratory impaired, here lies the real trick. If you don't have proper exposure in ventilator technology or proper knowledge of respiratory care, you may not be able to ventilate all this subset of the patient because of where you are giving here, that is disease. So you have to be very careful about the knowledge of the disease, parenchymal disease also. Now comes what are the types of mechanical ventilation. There are two types. One is invasive, other is non-invasive. You are very much acquainted with the term. First I am coming to the invasive. Today's workshop, I will only concentrate on this variety, invasive variety. It may be white endotracheal tube or tracheostomy tube. So whether it is an endotracheal tube or tracheostomy tube, to us it is the same. What we will do, invasive ventilation, the basic technological term is IPPV. What is IPPV? Intermittent positive pressure ventilation. The term itself qualifies what I have said now in the master diagram. That means a flow starts and stops. Intermittent. A positive pressure is going to the patient lung and is coming out of the patient lung. So this is basically IPPV. What are the basic types of IPPV? One is the full support to a patient who is totally dependent on ventilator. It may be totally paralyzed by the relaxant, or maybe due to the central cause, or maybe due to poisoning, or whatever may be the reason. When a patient doesn't have any respiratory flicker or anything, that patient requires a total ventilation. That means your machine is taking take care of entire ventilatory process. So this is known as full support. Then another variety of IPP, the partial support. What is partial support? Suppose I am a patient. I am having a problem. I need a ventilator support. Why? Say my demand is 6 liters per minute volume is the demand. I am able to generate 3 liters by my own, or maybe muscular disease, maybe Gueberi syndrome or anything. I can generate 3 liters of respiration by my own effort. I am in each minute I have a shortfall of 3 liters. This 3 liters has to be supported by an additional equipment, means ventilator. So this type of ventilator support is known as partial support. Some portion is taken by the patient and rest is taken by the machine. Now what are the varieties of full support? CMV. Controlled mechanical ventilation. That means patient lung doesn't have anything. Say your patient respiratory system or brain doesn't have anything to say. What I have decided, I have delivered to the patient. So it is absolutely dictated by the operator. This is the classical variety of full support. Now it has got 2 different broad classifications. One is volume control, one is pressure control. What is the volume control? It determines a preset volume. Again, this 6 liter, say 10 is my respiratory rate. What will be the total volume? 600 cc. Minute volume divided by the respiratory rate is the total volume. So, any tidal volume, if I determine, fix a machine, that A to D converter, all this in the master diagram and in the setting, say I have set 500 cc or 600 cc here, the volume. The machine will deliver up to that mark, whether what I have said. 500 ml will go to the patient. This side is the machine, this side is the patient. 500 cc will go to the patient. That will not look at the patient whether this 500 ml may burst his lung or anything, do parenchyma damage. Only determinant thing is the volume. The quantum of air has transferred from machine to the patient. This is volume control. But another way of control mechanical ventilation is the pressure support or pressure control. What is that? I have set a peak pressure, say 30 centimeter of water. This transfer of air will reach up to the patient at a level of 30 centimeter of water. Then it automatically will stop, this valve, exhalation valve will open. So target is 30 centimeter is set. This 30 centimeter may be done by 100 ml air, may be done by 800 ml air. That depends upon the elasticity and resistance of this side, the patient side. Here the determinant is only the pressure. So these are the 2 broad classifications of control mechanism. One is the volume transfer, other is the pressure target. So it is, I think, clear up to you. Now come to the non-invasive. Non-invasive means nothing goes into the patient's airway. Neither an endotracheal tube or a tracheostomy tube. The classical example is the mass ventilation. Now there are a lot of adjuncts are coming, LMS, IGL and all these things. This non-invasive ventilation, basically you can do all this type of ventilation with non-invasive way. But there are some specific modalities on non-invasive type. What is positive pressure via a nasal oxygen? The same thing, the technology, it goes into the patient. The classical example is the CPAP, continuous positive airway pressure. What is that? A certain air column is maintained within the respiratory tract of the patient and the interface, means the breathing circuit. This has been learned from the patient, and patient has learned by the inception of the human being generation. Have you seen a COPD patient in your house or in a hospital? What they do? Most of the people, they sit in a chair and so they learn by themselves that if they exert against the resistance, then some air column is maintained that they are very better. From that we mimic in the continuous air of pressure. Without any machine you can do it very easily. If you put a polythene bag around the face of the mouth with a cello tape, put some holes for going air into the. That is the classical example of CPAP. That can be. So now you have understood that we can do, because I have a control on the machine with a acceleration valve. If I do not open this thumb, the acceleration valve is nothing but a thumb. If I do not open this thumb fully, partial opening, that is CPAP. That means some amount of air is remaining in the patient's lung. So this can be done by face mask very easily. That doesn't require any intubation or anything. Now comes BiPAP. This is a two level of pressure. The first one is a single level. What I have said now, that is single level. Now if you have, your machine is having a logic circuit inside. You have a command arrangement with the machine that first say 5 centimeter water, second is a 10 centimeter water. Sequentially it will operate between the two levels of closing and opening of the thumb. So this is not BiPAP. Nothing new in it. Now comes negative pressure. Up to this, what I have said, this invasive IPV, positive pressure, non-invasive, these are all unphysiological ventilation. These are all unphysiological ventilation. Why? Go back to your school, first year classes. How a patient breathes. What is the mechanism of breathing? It is a three-spring model. It is a three-spring model. One central spring here, two lateral spring like that, and is a pull. When this spring pulls up, means the diaphragm contracts, what will happen? The chest wall gets inflated, and with the chest wall and the diaphragm, there is the attachment of the parietal pleura.